Hey everybody, welcome back to the ECG channel. My name is Reid, and don't forget that you can download this PDF so that you can follow along down, linked in the description below. And so let's go ahead and get started. This is a fun rhythm. I really enjoy these ones. And so let's see, when we look at the forest, right, we kind of find a QRS complex. Maybe we'll pick here lead 2. And what you'll notice is that we've got a wide complex QRS. We've got a wide complex rhythm that is marching very slowly through this strip. It's very regular, but it's very slow. And so let's see if we can calculate the rate here. If I find a QRS that's on a solid line, maybe like this one right here, we would go 300, 150, 100, 75, 60, 50, that's 43. So we'll call this like 38 beats per minute. Right, kind of the ballpark, but we know it's quite slow. And so when we see slow, regular complex rhythms, we need to either think, one, is this a junctional rhythm with like a bundle branch block of some sort? Two, is it a ventricular rhythm? Right, those are scary rhythms because they would potentially need a pacemaker. In the ventricles, and when we think of these, we think of them as escape rhythms, right? So they're going to be regular complex, but there can also be sinus rhythms. And if I look, in front of each QRS complex, I do notice that there are P waves, right? You probably noticed the same thing. There are P waves in front of my QRS complexes, and they seem to be kind of in the same place every time. So I'm like, huh. Interesting. Maybe wasn't expecting that. So if I have P waves in front of my QRS, maybe I'm thinking either a sinus bradycardia, or maybe I'm thinking like a high grade AV block, right? Like a 2-to-1 or a 3-to-1, right? 3 P waves for 1 QRS. So we gotta kind of figure that out. And so let's take a look at those P waves. What is the atria doing? And see, I've got a sinus beat that is upright in lead 1 and it's upright in AVF. So that tells me that it's coming from the sinus node, right? It's coming from the sinus node. So now I'm like, well, what is my AV node doing? Is my AV node conducting every P wave to a QRS? And how is it doing that? So I look at the PR interval first, and I see my PR interval here is within normal limits. So my PR interval is within 120 to 200 milliseconds, which is normal. When I scan through all of the beats, I notice that every PR interval seems to be the same. And I look in the middle of the QRS complexes to find any extra P waves. And what's interesting is I don't see any. Right, and I do it in multiple leads to make sure I'm not missing a certain morphology, right? Scan through, and I don't see any, right? You don't see anything up here. And so this must just be a severe sinus bradycardia, right? If every P wave is connected to a QRS is just going this slow, it's pretty remarkable. And so now let's take a look at the QRS complex. We initially said the QRS complex was wide. And let's measure the QRS. If I come here, that QRS, the QRS complex is greater than 120 milliseconds. So that tells me that when the AV node receives that signal, albeit at 38 beats per minute from the sinus node, when it sends it down, it's sending it down in a wide fashion. So there's some type of aberrancy. So we think of bundle branch blocks, right? I look over here and I do see immediately this R, S, R prime, and V1. And that tells me that there is a right bundle branch block. But I also notice something else. I notice that, let me erase this just a hair. I notice that my axis is positive in lead 1, but negative in AVF, right? And it's also negative in lead 2. So it tells me my axis is up and to the left. And so when you have left axis deviation in the setting of a right bundle branch block, you look and you see you've got this little q big R and this little r big S, and that is also a left anterior fascicular block. So this patient has a right bundle branch block, left anterior fascicular block. We also can call that a bifascicular block, right? This person's got some serious conduction disease, right? They've got blocks throughout, you know, a couple of their fascicles. Their sinus node is going really, really slow. You know, so the person's heart's not working the way it should, but we're still getting some perfusion, thankfully. So that's our QRS morphology. I look at the QT interval, and you can correct the QT here. You can see that these T waves, if you corrected that for the rate, I'm not going to do it here, but that's a normal QT interval, right? And so then I look for pathological Q waves and ST and T wave changes throughout, and I don't see any of those, so no acute ischemic changes and no chronic ischemic changes in the setting of like a Q wave. And so what do we have here? We've got a sinus rhythm at a rate of 38 beats per minute, so that would be a sinus bradycardia, right? We have a bifascicular block, which is a right bundle branch block and a left anterior fascicular block in this case. So kind of a funky rhythm here. You know, I think what's really important when you look at this rhythm is, do you have the tools to make sure that this isn't a high degree AV block, right? And so you can treat this patient accordingly, right? Look at their medication list. Are they on any, medications that suppress cardiac excitability, like a beta blocker? Can we maybe decrease the dose and see if we can get their sinus node to be a little faster? Things like that, right? So I hope this helps, and leave comments with any questions that you have. And yeah, thanks so much for watching. We'll see you on the next ECG video. Have a good rest of your day.